the orthoPAC, hosted by Sam Dyer. Welcome to the orthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice. Welcome back, listeners. Today we have part 2 of our interview with Dr. Maiers. Dr. Maiers, when we left last week, we were discussing the history, physical exam, and workup of athletes with hip pain. Let's please now talk about some different diagnoses you have seen in athletes with hip pain. You presented multiple case studies with various diagnoses, and I was hoping we could chat about those. Some of these are intra-articular and some are extra-articular. Okay, first up, femoral neck stress fractures. What are some of the risk factors of femoral neck stress fractures, and who might be most likely to have this?
General risk factors for stress fractures, you worry about, females, the female triad. So, amenorrhea, anorexia, and low bone density. So those are the ones that are highest risks, and it tends to be in people who are in sports that have a rapid increase in training. So you think of like cross country runners in the fall, and your track distance athletes in the spring. But we'll see them in basketball players and in different athletes. But those seem to be the ones that are the highest risk.
How do you diagnose these? Do they typically show up on an X-ray?
Not very often. Usually this is an MRI diagnosis. You have to have a clinical suspicion. So somebody comes in with a history of hip pain in that population that is you worry about. You'll ask about a menstrual history, ask about their diet. But if I have a runner that is complaining of an increase in hip pain, I'm pretty liberal with getting an MRI scan just because that's one of the few diagnoses that I don't think that we can miss.
And as far as treatment, are they usually treated conservatively, like with crutches and non-weight bearing, or do they usually require surgery?
Almost always are non-surgical interventions. So we'll have patients utilize crutches for activities that cause pain. So if they're having symptoms with, and these are usually students, but not always, if they're having symptoms kind of just walking around with everyday activities, we'll put them on crutches and allow them to be, weight bearing is tolerated with the crutches to help take some of the pressure off. When their symptoms resolve to the point where they're no longer having pain with activities of daily living, they can start weaning off their crutches, and then we let them increase their activity as tolerated. But it's usually we'll start them on an elliptical trainer or bike at about 3 or 4 weeks after diagnosis, as long as they remain pain-free, and then progress them back to progressive upright activity, including the Stairmaster, maybe an Alter G or a HydroWorks, up until usually around 3 months is when we let them start to begin full body weight running.
Okay, next up, femoral acetabular impingement, FAI. This has become very popular in the last 10 years, maybe 15 years. Anyways, please give our listeners an overview of FAI, i.e. CAM, pincer impingement, sometimes both. You said that many people have radiographic evidence of this, but also many are not symptomatic. What is the typical complaint when you see a patient who is symptomatic?
Most of the time, people will complain of some discomfort in the anterior aspect of their hip. Sometimes it radiates to their anterior thigh. Typically, long car rides will bother them, or sit in a movie theater or on an airplane, that'll be uncomfortable for them. Oftentimes, they'll experience more difficulty with rotational movements than they will straight plane movements. So it may be somebody that says, I can run straight distances for as long as you want me to, and I get a little bit of achiness. But if I'm a soccer player and I have to, cut and change directions, I'll get a sharp pain in my hip. Or if I'm a tennis player and I have to lunge for a ball or a quick change of direction, that's when it really gets me. So those are the more common complaints in terms of athletes. People that are non-athletes or weekend warriors, it might just be if they have to get in their car, they have to be careful how they get in and out of their car, because they'll get a sharp pain in their hip with certain rotation.
What is the role of ultrasound-guided injections for these patients? Can it be both a diagnostic and therapeutic intervention?
As you mentioned earlier, it's very common for these people to have multiple findings on their MRI scan, or for them to have, not everybody comes in with a classic exam of a positive C sign and pain with, kind of a fader test and x-rays that are super classic for FAI and an MRI scan that looks like a very clean labral tear. So when we have patients whose symptoms are either not totally classic, or if we're trying to figure out exactly what symptoms are coming from their hip joint, what symptoms are not coming from their hip joint, we'll use an ultrasound guided injection of local anesthetic in the office. We'll examine them. If we can elicit hip pain with the exam, great. We'll have one of our physician assistants do an injection, let that local anesthetic set up for 20 or 30 minutes, and I come back in and re-examine them. And I always tell them, I'm like, whatever pain we relieved with the injection, we're pretty confident that's coming from your hip joint. And whatever pain that you still have, pretty confident that's not coming from your hip joint. And that just lets the patients know and lets me know what pain is related to their hip and what pain is related to something else.
And when is surgery indicated for FAI?
Surgery is, in my opinion, if it's you have symptoms that are unacceptable with your quality of life, you've exhausted non-operative treatment, which consists of structured physical therapy, sometimes corticosteroid injection, depending on the duration of your symptoms and the things that are bothering it. And you have exam and imaging findings that are consistent with FAI. So those are the things that have to kind of all come together for someone to be a candidate for surgery. Cam impingement is probably the easiest one to identify radiographically for people who aren't used to looking at a lot of hip x-rays. And people have this kind of pistol grip deformity of the femoral head and neck junction where the proximal femur appears to be out of round. It's best seen usually on a lateral x-ray, but occasionally you'll see it on the AP x-ray. And that's just where the femoral head does not fit properly into the socket. And then pincer impingement can be either global pincer, where there's a kind of a global over coverage, or focal pincer impingement, where there's focal areas where usually the anterior or the lateral acetabulum kind of is, overhangs too far anteriorly or too far laterally, and puts the labrum in a position where it can get crushed by the femoral head neck junction as one either flexes or rotates or abducts their hip.
Okay, next topic, apophyseal injuries and heterotopic bone. Is this a common etiology of hip pain in the athlete? Who is the typical athlete that might experience this? Junior high, high school, other level?
Apophyseal injuries are pretty common, particularly in your adolescent athletes. A lot of times it's sprinters or kicking athletes. We see them about, depending on the bone age of the patient, but usually I see a lot of these in kids kind of 14 to 16 or 18 or so. And usually they respond well to some rest, and typical duration is about 6 weeks before they're able to return to sports. I would say it's fairly uncommon for us to see significant heterotopic ossification as a result of one of these injuries. It's usually, when we see that, it's usually an indication they've had multiple apophyseal injuries in the past.
What would be some of their common complaints, and how would you manage these?
Again, if they're having trouble walking, we'll put them on some crutches just until they're comfortable walking. They'll start doing physical therapy typically 2 to 3 weeks in, just trying to maintain a little bit of cardiovascular fitness, avoiding stressing the injured area. Then as the bony injury calms down, they can start progressing some of their physical therapy exercises and their strengthening exercises. And then it's usually around the 6-week mark, I test them, which means we have to press on the affected apophysis and it has to be pain-free. And then we have to stress the muscle that originates from that apophysis. And if they don't have pain with that and they've got good strength, then we'll allow them to return back to play.
Hip subluxation and loose bodies. If there are loose bodies, is the articular cartilage the typical donor site? Is it common to have labral pathology as well? Do these all typically get arthroscopy?
Loose bodies, yeah, I mean, usually the origin of them is articular cartilage, either from the femoral head or from the socket. And again, it just depends on if they're having symptoms from them. Sometimes somebody may have a subluxation episode, knock off a small piece with some rest. That piece may find some place to hide and not be symptomatic for them. If they're not having mechanical symptoms and their hip starts to feel pretty good, we just leave them alone. If they do continue to get sort of that catching and locking, or if there's a large piece, those are indications that they may require surgery. And yes, oftentimes you will find labral pathology at the same time. And if we find that, we'll address it typically with a repair.
Psoas impingement. Okay, you mentioned that this problem typically presents with a painful snapping of the hip. What physical exam maneuver is most likely to be positive with this problem? How do you manage these patients?
Patients with psoas impingement, they typically will have pain and snapping when you go from a position of flexion, abduction, and external rotation to extension and internal rotation, and they'll experience a kind of a painful catch throughout that range of motion. The initial treatment for this is some physical therapy to work on core strengthening, abductor strengthening, stretching of the hip flexor musculature. If that doesn't work, then you can do an iliopsoas tendon release or fractional lengthening of the iliopsoas tendon. That's not something that we do very often, but it is something that can be done. Most of the time, isolated psoas impingement does resolve with some physical therapy.
Here's something I haven't really heard of or thought of: ligamentum teres tears. Dr. Maiers, you said that this is a common injury in the gymnast as the mechanism of the injury is hyperabduction. You also said bull riders and rodeos may have this, as well as some women during childbirth from prolonged abducted hip positions. What sort of complaint will the patient have beyond pain? Does it feel like it catches, locks, gives out?
That's exactly right. So they'll often will experience catching and locking. And most of the time, these are found in conjunction with labral injuries as well. But we have seen a few patients that have had isolated ligamentum teres tears, and they come from a hyperabduction injury. Unlike some other joints in the body, a lot of the complaints that people have with regards to their hips tend to be similar, whether it's labral pathology or ligamentum teres tears or loose bodies, just because the hip is not as well innervated as say the tip of your finger, where we're very sensitive about where we're experiencing pain or discomfort, and the hip is just not that clear.
Listeners, please join us again next week with part 3 of the interview with Dr. Maiers, when he discusses some more of his own clinical experience with different hip problems and how they are managed. Thank you for joining the orthoPAC podcast. We also welcome you to visit our website, paos.org, where members can download virtual conference content and get Category 1 CME. Also, if you're a non-member and you're interested in our CME content, please visit the aapa.org Learning Central for the PAOS virtual content.